Morning or good afternoon, everyone. Thank you all for joining us today in our Tailoring Your Treatment with Biomarker Testing webinar. My name is Zach Getty, and I am the Education Manager here at Fight CRC. Fight Colorectal Cancer is the leading patient empowerment and advocacy organization in the United States, providing balanced and objective information on colon and rectal cancer research, treatment, and policy. We are relentless champions of hope, focused on funding promising high-impact research endeavors while equipping advocates to influence legislation and policy for the collective good. Before we get started, as always, I have a few housekeeping items that I like to go over for every webinar. We will have some dedicated time at the end of this webinar for general questions, but please feel free to use the Q&A panel on the right side of your screen to ask any questions that might come up along the way. This webinar is meant to educate as well as serve as a forum for you to ask your questions and start conversations, so please don't be shy. We will do our best to answer any and all questions that are asked, but please do keep in mind that we may not be able to answer hyper-specific questions about your treatment or your specific diagnosis during this event. There's often just a lot of information that goes into these types of questions that we just won't have access to. But don't let that discourage you from asking questions. We will have a recording of this webinar available on our site within the next few days. You will receive the direct link via email as soon as it is available if you've registered for this webinar. We will also provide a transcript of this webinar on our site for those of you that would prefer to read the information discussed today. Also, please feel free to tweet along with us. You can use the hashtag CRCwebinar. Please remember to stop by our website at fightcrc.org to check out all of our patient and caregiver resources. We offer a variety of free-to-use online tools, such as our clinical trial finder, which provides a curated list of colorectal cancer-specific clinical trials. We have a patient provider finder, which allows you to search for providers in your area with experience and expertise in treating CRC. And Chat CRC, our one-of-a-kind interactive tool that can answer your questions about colorectal cancer and related topics, which is available on our website or by text at 1-318-242-8272, which is 1-318-CHAT-CRC. There's also our free Community of Champions app where you can connect with other people in the colorectal cancer space and keep in touch with Fight CRC and know what we're up to. In addition to all that, we also offer an assortment of print and digital educational resources that are free to request and download. Those are available in English, Chinese, and Spanish languages. Quick disclaimer, this information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you're ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatments for any condition. Okay, now with all of that out of the way, I'd like to briefly introduce our panelists. Joining us today are Dr. Marc Roth, gastrointestinal medical oncologist at St. Luke's Hospital System in Kansas City, Missouri, and Sydney Stoner, stage 4 survivor and advocate. I am going to give both of them a chance to introduce themselves, but first I want to thank them both for taking time out of their busy schedule today to join us. Sydney, I'll start with you. I'll let you just give a little bit more in-depth introduction, and then I'll hop over to Dr. Roth, and we will get into the meat of this webinar.
Hi, I'm Sydney Stoner. I'm 31. I was diagnosed with stage 4 colorectal cancer at age 27 in September of 2020. I'm on my 4th line of treatment, so I'm on Monsurf and Avastin right now.
Thank you, Sydney, and thank you so much for joining us. Dr. Roth, if you want to introduce yourself a little more thoroughly than I have.
Sure, and yeah, thanks for having me, and thanks, Sydney, for being here. So, as you mentioned, my name is Marc Roth. I'm the medical director of gastrointestinal oncology at St. Luke's Cancer Institute here in Kansas City, Missouri. So I specialize in GI cancers, not only in colorectal cancers, but certainly given how common that is, it's definitely the bulk of my practice. And so I'm happy to be here today. I will say that this kind of topic is a special interest of mine, and I think is becoming a I won't say special interest of all oncologists, but a necessity as far as having to be familiar with biomarker testing as the oncology field evolves. Last thing I'll say is that I am sorry if you hear ambulances. There have been quite a few of them in the background. So when I'm not talking, I'm going to try to mute so that you guys can hear a little bit better.
Somewhat par for the course, I imagine, based on your background. So, well, thanks for joining us. I'm looking forward to having a conversation. Fight CRC spends a lot of time trying to educate patients, caregivers, really anyone that'll listen about the importance of biomarker testing, tumor testing, whatever you want to call it. So having you here and to kind of share that interest is really awesome. So I'm going to go ahead and kind of start jumping into the slides here, and we can go from there. So let's get started. So Dr. Roth, can you give us an idea of what biomarkers are?
Yeah, and when we were talking about this, I was thinking how little I actually use the term biomarkers because, and you're going to go into this in the following slides, but it is such a broad term that using it, I feel like almost kind of confuses patients even more because there's just so many kind of subtypes and each have a different role. But very broadly, biomarkers are not necessarily unique to cancer cells, but are basically, you know, markers that that correspond to potentially proteins that are made by cancer cells or DNA in cancer cells. So whether it's blood tests or tissue tests that we're sending, it is kind of an all-encompassing term for testing that we get outside of your run-of-the-mill, like kidney function testing, liver function testing, electrolytes, blood counts that can help modulate your care longitudinally.
Excellent. So they're not necessarily specific to cancer, but they do play a unique role in the treatment of cancer.
Yes, yes. Treatment, so diagnosis, treatment, monitoring, prognosis, all of those, and kind of those were all separate buckets of biomarkers that we're going to delve into.
Awesome. What aren't they?
Yeah, so I'm just going to walk through these specifically. So having your biomarkers tested is not the same as having genetics tested. That is a very complicated, I think, concept for a lot of patients to understand because a lot of times it might be the same company that we're sending to test your genetics and also your genomics. And so it can get very confusing. But when for most and this is one of the reasons why I don't use the word biomarkers, I feel like very often. But when we say we're going to perform genetic testing, it's usually in relation to actually the picture that you have there on the right side of the screen, which is do you have some sort of hereditary cancer disorder or predisposition to developing cancer based on the DNA that's in your body? Okay, so it's DNA that you got from your parents. This genomic word, which is very similar to genetics, but genomics kind of refers more to what is what are the underlying DNA changes that might be driving your cancer to grow. Okay. Sometimes they're the same. So sometimes that gene that causes that predisposition is the same, that you got from your family is the same that's causing it to grow and something that we can target, but sometimes it's different. So I would say that the genetic portion is, did you get this? Did you develop this cancer because of DNA that you got from your parents? Is there a risk that you're passing it along to any children you may have, or are your other relatives at risk? And then that genomic portion is tells us more about your tumor and maybe how we can treat it more effectively.
Interesting. So genomics is kind of a drilled down unique to your situation, while genetic is a little bit broader, relating to your family and what you may or may not pass on to children.
Right. And more specifically, I would say that genetics looks at DNA in every cell of your body. Okay, normal cells and cancer cells. That genomic portion really refers to, generally speaking, just the DNA in the tumor itself.
Okay, interesting. Thank you. And you said you don't like to use the term biomarker. What term do you prefer to use when you're discussing this with patients?
So that's why I will say either genetics or
Okay.
genomics or tumor markers, which are also biomarkers, but are not necessarily in the same ballpark as genetics and genomics.
Thank you. All right. How do I know what my biomarkers are? What's the process? How do I get tested?
So it is generally a combination of a blood test, a tumor test, and and sometimes a saliva test. So this goes back to that investigation of all the DNA in your body. And so maybe we should exclude that for the purposes of this because it's really just talking about that more targeted DNA within the tumor itself. So actually, maybe forget that I said that. Try not to confuse you all more. But how we typically test is, like I said, a combination of a blood and a tissue test. That tissue test can be the same tissue that originally diagnosed your cancer. So in the case of colorectal cancer, maybe you had a colonoscopy. They got some tissue with a biopsy, or maybe you had a surgery to remove the tumor. That is also sufficient, of course. Maybe you had cancer in a spot in your liver or your lungs, and they biopsied that. So we can send any of that tissue off for subsequent studies, those genomic studies. That is kind of the original way that these genomic tests were developed. More recently, probably within the last 5 years or so, we've been sending more blood-based testing as well. So one concept I try to explain to patients as to why we would be testing your blood if your cancer's in your colon is that all of our cells spit out DNA into our bloodstream. Okay. Now, in cancer, we're looking specifically for tumor DNA that's spit out into the bloodstream. And so when we're testing your blood, we're really looking for substances that your tumor is producing that is circulating throughout the body. So that's why we might be testing your blood, even though the cancer is in a different location.
So specifically with tumor biopsy, you said these may be taken like during surgery or during a colonoscopy. Is it just a one and done approach? Is there a chance for having to get back into receipt or to retrieve more tissue from a tumor? Are there any specifics with that people might need to be aware of?
Yes, absolutely. So this is something that happens not infrequently. Well, I should say that ideally, right? You get a colonoscopy, they get a diagnosis, and then you're done. But if I think it's worthwhile explaining or going into a little bit more detail here, because some of you might have experienced this. When we see a tumor in the colon or the rectum, oftentimes there are normal cells on the outside of that tumor. And so it is not guaranteed that if you take a sample of that tumor, that mass, in other words, that you're always going to get cancer cells. And so sometimes you do have to go back and do a second biopsy, even if on imaging it is very consistent with cancer. And the reason why is because those tissue tests are so important to be able to get. And so that's why sometimes we have to go back, but that's also one of the strengths of, and we'll talk about this later, but one of the strengths of this blood-based testing now, and that, sometimes if we just can't get the tissue, maybe it's in a really difficult spot to biopsy, we can fall back on the blood-based testing. But sometimes it's just per this slide, just to go over a little bit more. Sometimes we're doing incisional biopsies where we're just taking a small piece, which is what I was referring to. Sometimes it's an excisional biopsy where it's the whole tumor. And sometimes it's a full resection in the case of colorectal cancers, where you're actually going in and removing not just the tumor, but a portion of the the normal colon or the rectum and the surrounding lymph nodes and soft tissues. If you're doing needle biopsies, there's a few different types. There are FNAs, fine needle aspirations. Typically, we do try to get a little bit larger of a sample with something called a core biopsy, because some of this genomic testing is really difficult to do on very small amounts of tissue. So in other words, the more tissue that we can get, the higher likely, the more likely it is that we're going to be able to get the information that we need to treat you appropriately.
Let's talk a lot about liquid biopsy and those blood draws and the screening for that.
Right. So I like to get liquid biopsies. Well, we'll kind of talk about this maybe more so in our stage 4 metastatic population, but I like to get, if I'm going to get genomic testing on tissue, I like to get blood as well. And the reason why is because if you going back to that analogy I was giving earlier about just taking one tiny piece of a large tumor, that one tiny piece may not be representative of every cancer cell in that whole tumor. That's something, I'm going to use a big word, but I'll explain it. That's something that's referred to as tumor heterogeneity, meaning that there can be different, even though it's all one tumor and a cancer, there can be different types of, or variations, I should say, on the same cancer cell. And so by getting a blood-based test as well, it really increases our understanding of what's going on inside that tumor rather than that one tiny sample that we got with a needle. So that's one of the benefits of liquid biopsies, which are just blood tests. And then another benefit is that sometimes, as I mentioned, we just can't get a biopsy because maybe it's in a really difficult spot. That tumor's in a really difficult spot to reach or dangerous spot to reach. There are a couple different types of liquid biopsies listed here with circulating tumor DNA or ctDNA, and that's kind of what I was referencing before. Circulating tumor cells are not as mentioned at the bottom here. They're not used as much specifically with GI cancers. That doesn't mean that they won't be in the future, but usually when you're talking about liquid biopsies or peripheral biopsies is another way to refer to those, they're generally talking about circulating tumor DNA.
Thank you so much. So what happens after I get a biopsy, liquid or traditional?
So we have to play a little bit of a waiting game because a lot of those tests take a little bit of time to process. The turnaround times are getting quicker as technology improves, but for liquid biopsies, it's typically probably 2 to 3 weeks. For solid tumor biopsies, it's maybe closer to 3 to 4 weeks. And so it may not be that we can always wait on that result before starting treatment. Sometimes we can. It really depends on the clinical situation. But there are several different types of genomic tests. They're listed there. So single biomarker tests, those are ones that we might get upfront and very quickly. So those tests are the ones that actually might change the management that we would initially start to treat you with. And so those are often tests that we'll do, or that most hospitals will do at their hospitals. Okay, so a pretty quick turnaround time of a few days. As we work down, they kind of get more complex. So multi-gene tests or panels are maybe looking at multiple genes. They might be done at the hospital, or they might actually be send-outs. And that depends a lot on how many, basically how big the hospital is and how many samples like this that they're processing. Whole exome and whole genome sequencing are very complex tests, and those are the ones that take a little bit longer, closer to those 3 to 4 weeks. One term that I want to point or direct your attention to is under whole genome sequencing, which we also refer to as next generation sequencing. Both of those are mouthfuls. So I just call it NGS. That's a little bit more commonly used phrasing. And that's those are very large panels of genes that can be very informative as far as how we can potentially treat your cancer.
So you kind of touched on this already, but you've got a couple weeks of lead up time after the sample is taken, and then assuming a report is generated after that and provided to patient's physician.
Yes. So patients, and again, depending on your health system, many times patients will get these results at the same time as the physician. And so the physician will usually review these, of course, and sometimes they're very obvious and we know exactly what to do with them. And we'll kind of talk a little bit later on about some of those specific examples. Other times it is not clear what to do. And so this is why we have many institutions have precision tumor boards or precision clinics where we can say, okay, this is a very unique finding on this. Is there any data to support, kind of treating off the beaten path, so to speak? But that is really an integral I would say resource in many oncology practices these days is having access to a precision clinic, precision tumor board, precision pharmacist, somebody that's specialized in being able to interpret some of the more complex and rare findings on these.
Fascinating. So to that end, we actually have, we had an advocate send us, this is an actual biomarker report that was given to a patient. And I wanted to include this as just a real example that people could lay eyes on, that how these are broken down, and that I think that the big thing here is that results with therapy associations for us, so that it's just spelled out pretty clearly. It's not always this simple, is it?
Right.
Yeah.
Right. So this is exactly what I was referring to earlier about those specific examples that are obvious for most oncologists. So KRAS and NRAS and BRAF, these can all be drivers of your cancer growing. And so these are samples that many times a hospital will perform immediately upon diagnosis of a cancer, because it directly impacts the first line of treatment that you might go on to as a patient with cancer. They are also included in these bigger panels, and you're seeing the rest of the panel there below. But the results there, as you can see very clearly, spell out when to use a drug or maybe when not to use a drug, which is the example here based on certain results. Most guidelines recommend at least getting the top 3 examples there, as well as the first 2, MSI-High and NTRK. But many panels have upwards of 500 different genes that they test. And so those panels are always growing as we learn more about tumor biology and as additional drugs are being released onto the market. So again, underscoring the importance of people or clinics that have experience in interpreting these really complex tests in an evolving field.
Sure. And you mentioned evolving. This is the second half of the report, and there's a whole area there specifically called out for we found mutations, but we're not sure if they're significant or not. Is that common?
Absolutely. I think probably every or close to every patient will have what we call VUSs, or variants of uncertain significance. So I think it's worthwhile explaining that a little bit, because I do get a lot of questions. What does that mean? What does it mean for me? So usually reports will classify changes in DNA called mutations as either pathogenic, meaning likely to have some role in your cancer development or growth. And then, as you'll see at the bottom, this variant of uncertain significance. What that means this is probably an oversimplification, but what that means is that we found this abnormality in a gene that the gene itself, when, has role in cancer development, but that this specific mutation in this gene is not known to cause the protein that results from that DNA to misbehave. Okay, so there's an abnormality there, but there really isn't that strong of an association of that change specifically being involved in the cancer.
So, wow.
And the other important thing is that sometimes those VUSs change over time. So I mentioned that we're getting a lot more information, especially as more and more people get tested. So it's not that that VUS will always be a VUS, but it's just saying that, like, given the current evidence that we have, we don't think that this abnormality is playing a role in your cancer.
All right, thank you. That's a lot to take in. So, and I know this topic is really dense. So we're going to get into a little bit of when does testing need to happen based on stage. I know that, treatment is different for the stage of cancer that depending that you're diagnosed with. So I've kind of broken it down into the, stage 1 through 4 and which tests may be appropriate based on your stage. So this is just a rough overview, but I'm actually just going to skip ahead and just get right into stage 1 if that's all right with you. So stage 0 or stage 1?
Yep. So stage 0, just FYI, is it basically means that there are cancer cells in your colon or rectum, but they haven't broken through the basement membrane. So basically, the first layer of the colon, those cancer cells are on top. What defines cancer is being invasive through that membrane. So that's why it's stage 0. Stage 1 is really just cancers that haven't invaded through the colon or the rectum wall very deep and don't have any lymph nodes involved. So we still recommend some biomarker testing. For all colorectal cancers, we recommend MSI high or dMMR testing. The reason why is because it is a first-line screen for one of our most common hereditary cancer syndromes for colorectal cancer called Lynch syndrome. And so, knowing whether or not you have this finding directly impacts you because it informs us what is your future risk for developing more colorectal cancers or other types of cancers related to Lynch syndrome. It also tells us whether or not your family members might need to be tested. And in certain settings, it also has treatment implications. So it definitely changes how we would treat you. So for that reason, even if there's not a treatment implication in the first line, or sorry, in stage 1, we still recommend checking for that. So that's a tissue biomarker. CEA is a blood biomarker, or more specifically, I would describe it as a tumor marker. It is not the same as circulating tumor DNA. It is basically just a protein that your cancer can produce. The utility of checking that is that we would anticipate that if we're treating your cancer effectively, that your CEA is decreasing. Okay. If it's increasing, that may mean that the treatment isn't as effective. That said, and this is a whole different topic, but there are a lot of caveats for reasons why CEAs are not specific even to cancer. For example, patients that smoke or that are tobacco users typically or can often have an elevated CEA even outside of cancer. It's also not specific to colorectal cancer. You can see elevations in patients with certain types of lung cancers or other types of cancer, but it is standard to check this. It's also something that we monitor over time after a diagnosis of cancer. that maybe we cure, so we take it out surgically. If we're monitoring that blood test and we notice that it starts to creep up, that might be more suspicious that maybe something is coming back.
Thank you. Stage 2 looks pretty similar to stage 1 testing.
Yes, the only difference that I would say is kind of entering into the circulating tumor DNA. This requires a little bit of attention too, because there are multiple types of circulating tumor DNA testing that I think are important. Well, there's really two buckets. Circulating tumor DNA can be quantified, meaning that we can assign it a number, kind of like a CEA. Okay, so it can be a tumor marker in that way, and it can help us say, is there a chance that there's still tumor in your body, or basically how well is that tumor DNA responding to treatment? That's quantitative, meaning we assign it a number. Then there is the other bucket, which is qualitative, meaning what does that tumor DNA actually look like? That's where we get into the specific genes that were mentioned on the previous slide. So do we see a KRAS mutation or a BRAF mutation in that DNA? So in this stage, we're not so much looking at which mutations are present, because that doesn't really change the way that we manage your cancer. However, if we notice that we've assigned a number to your ctDNA, if that's not 0 after a surgery, then in other words, if it's high, that might indicate that there might be some cancer left over, and we might treat you differently. On the other hand, and this is pertinent for both stage 2 and stage 3, if we diagnose you with cancer, we surgically remove it, and we're recommending treatment for it, like chemotherapy, but your ctDNA is 0, indicating that maybe you don't have cancer, any residual cancer, is there an argument for decreasing the amount of chemotherapy that you need? And that topic is constantly evolving right now. Most providers are not at the point where they are what I would call de-escalating treatment based on a negative ctDNA marker, meaning they're saying you don't need chemotherapy just because your ctDNA is 0. But that is a question that we're trying to answer in the oncology field, because while we want, of course, to increase the chance of a cure, the toxicities of treatment are very real. And so we want to make sure that we're not over-treating patients that don't need to be exposed to chemo. So that's something that I think we're going to have an answer to in the next 5, probably the next 5, if not definitely the next 10 years.
Wow. All right. Stage 3, again, similar to stage 2.
And there's a question here that I just saw.
Oh, yeah.
If an early stage patient has a positive ctDNA test after surgery treatment, do you support getting their tumor marker testing done? So definitely CEA, but not necessarily genomic testing. It really depends on kind of what the treatment looks like. There are so many caveats and nuances to ctDNA testing. I mean, for example, if you check ctDNA right after surgery, it's probably going to be high. If you check it 8 weeks after surgery, you're probably going to get a different level. So timing is important. Chemotherapy and immunotherapy affect ctDNA levels. So that's kind of what we're trying to learn right now, is what is the variability between patients and how much can we trust it to make these treatment decisions. Otherwise, I don't really think that there are any changes or any differences between stage 2 and stage 3 disease.
How about metastatic disease?
Metastatic disease, different ballgame, absolutely. So we all should be, as medical oncologists, advocating for At the very least, these genomic tests on the very last or second to last bullet, KRAS, NRAS, BRAF, HER2, et cetera, I would say that the more common thing these days is probably going to be reverting to NGS testing those larger panels of genes, which are also going to almost universally include all the ones in the bullet before it. So it's kind of a kill two birds, one stone situation. If you're able to get at NGS testing, it will test all of the single genes that have been recommended before. There may be a role for ctDNA testing, that qualitative, that number that I'm referring to, in patients with stage 4 disease. One of the, although this is very practitioner dependent, so it may be that you shouldn't take my word for it, but my practice, one of the ways that I look for this is if we have stage 4 disease that we've cured. In other words, if we've taken out liver tumors and we don't see any disease left, kind of mirroring what it would be in a stage 2 or stage 3 setting, we could check ctDNA to make sure that if there is early evidence of disease coming back, that we're finding that early. Another incidence where we might check that would be maybe your tumor doesn't express CEA, so we don't really have a good blood-based way to monitor your tumor. But several physicians, several oncologists would disagree with me. Others would go further. It just goes to show you that right now we're all kind of learning how to use this new technology and how to make sure that we're using it to benefit patients.
Sure. Thank you. I think there we go. So this is, I put the slide in here just to kind of showcase this broad range of biomarkers implicated in colorectal cancer and maybe important. I don't think we have the time, nor do I want you to have to try to get into the specifics of every one of these, but there is a pretty broad swath of information that can be found out and of things that can impact their treatment. And that's really what I was trying to kind of highlight with this side, that there's a lot to look for.
Yeah, I was gonna say we could probably just leave it there. The discussion could have a lecture on every single one of those.
Yes, absolutely. And I've got more. So yeah, so we can just keep moving forward. But yeah, I think the importance of pointing out what biomarkers can do for you, if a diagnostic, prognostic, or predictive, and how that can impact your treatment.
So certain tests that we get, again, are going to be diagnostic. So they might tell you, for example, if we get a liver biopsy, is this most likely from your colon or your rectum, or do we actually think that this cancer came from the pancreas? That's one way that we use these diagnostic biomarkers. Another one would be prognostic. So we'll take the example of KRAS. Honestly, I think the majority, I think it's somewhere around 60%. 60% of colorectal cancer patients have like a KRAS or NRAS mutation, which are typically a little bit more aggressive. From a predictive standpoint, we can also use that same example. We know that patients that have those mutations do not respond well to a specific class of drugs called EGFR inhibitors, panitumumab or cetuximab, and so we check those to make sure that we're avoiding those drugs if those mutations are present.
Thank you. Okay. So into treatments that are impacted by biomarker testing. So I know typically immunotherapy and targeted therapies have the most impact, but I know there is at least one that should be tested if you're going to be getting chemotherapy. Can you talk about DPD at all?
Yes, so this is very interesting. This is something that's been known for a long time, but the United States has not had a global recommendation to test all patients that are going to receive 5-FU chemotherapy or capecitabine for DPYD. However, I think the package inserts on these drugs have just been updated within the last year. And so many hospitals are, you're right, many hospitals are trying to figure out how to incorporate this testing up front in such a way that we can get it done quickly prior to starting a patient on treatment. In essence, though, DPYD is a gene that is responsible, or the protein produced by this gene is responsible for the breakdown of 5-FU chemotherapy or capecitabine chemotherapy. And so if you have an underactive protein that isn't breaking that chemotherapy down as much, then the potential for you to have undue toxicities or side effects from chemotherapy that can be life-threatening is much higher. And so that's why it's increasingly important to check for this. It is rare, but if you're the patient that has this, then it's very important, of course.
Thank you. What about immunotherapy?
Immunotherapy is to date only approved in the case of these MSI-high or dMMR cancers, which colorectal cancers, which are unfortunately the minority of colorectal cancers we see. Depending on the stage and location of your tumor, it's anywhere between 5 and 20% of patients. I think 20 is probably a little high. Those are the numbers that I've seen, but in literature, but in clinic, it's probably closer to that, like 5 to 10%. But when we do see this, we get very excited because it opens up another option for treatment in the form of immunotherapy.
So there's a lot of information on this slide. Like I said, this will be recorded and you'll be able to access this. So there are some very specific use cases for these drugs that are listed here that are outlined on these following slides. So immunotherapy is one, and next we have targeted therapy, which I believe is a lot more broadly impacted by your biomarker results or genomic results, sorry.
Exactly. Yeah. Sometimes we have targeted therapies that are already approved, as you mentioned. So here, the BRAF V600E mutation, there's a specific drug, or it's actually 2 drugs that we use for that. And then there are several other mutations that we find that might have approvals in other types of cancer. So, for instance, I'll use the example of an FGFR2 fusion. There might be drugs approved in biliary tract cancer, but maybe you're one of the rare individuals that has one of those fusions present in colorectal cancer. And so sometimes we can get off-label approval for patients and still have effective, treatment efficacy.
Sure. So even if it's not directly approved for colorectal cancer, it is approved. I heard tumor agnostic. It doesn't necessarily matter where the tumor is so much as it has these mutations.
Right. And so sometimes it's not tumor agnostic. So sometimes treatments are tumor agnostic, and so immunotherapy is one of them, and actually BRAF inhibitors are another one. Maybe though it's only approved in biliary tract cancer, but they're never going to do a trial in colorectal cancer because the patient population is so small they wouldn't be able to. So then we have to argue with the insurance and pharma companies, say, here's the evidence that we have that it might be effective and it's in this particular type of tumor.
Okay.
That's where those precision clinics come into play.
Sure. So another page of targeted therapy impacted by biomarker testing.
This is actually a perfect example of what I just said. All of these drugs were initially approved in breast cancer, but because of expanded biomarker testing, we started to see that colorectal cancer patients, it's usually on the order of like 4 to 5%, had HER2 amplifications. And so then they started testing these drugs in colorectal cancer, and we've seen pretty impressive results. So now a few of these are on label actually for colorectal cancer, and more coming down the pipeline that will be approved, I'm sure, in the coming years.
Fascinating. And I think this is my last page of targeted therapy information.
Yep, and I won't go into these specifically, but what I'll say is that each one of these mutations at one point did not have a drug that we could target it with. KRAS previously was thought to be an undruggable protein. We never thought that we would have drugs that could target this. But because of advances in scientific research, um, investigators were able to develop drugs to target these mutations, and we certainly don't have one for every single variant in KRAS, but they're developing more and more all of the time. And so this is a really fascinating area of research in colorectal cancer right now, and one that probably has the biggest potential to change treatment uh, options soon.
Amazing. So we've thrown a lot of information at people over the last 45 minutes or so. What can people do with this? Take it to their physician. What do they do?
Yeah, I would just say that just always ask, like, what testing have I had done, and what does it mean? Because it's complex for us to understand, in an evolving field. Like I said, and we had decades of training, right? It's a lot to ask patients to understand all of this. So it's always okay to ask questions. Yeah, I think the first thing I would ask is, did I have this testing done, or do I need to have it done? Because we certainly don't need to check in every single patient. And then if you haven't had it done, ask if you can. And if you have had it done, ask what the results mean.
Thank you so much for taking the time to explain all this. I'm going to give Sydney a chance to kind of share her story and how this has impacted her personally. If you have any questions, though, please feel free to put them in the Q&A panel. We've got about 10 minutes or so left. We will try to address all the questions that we can, so please feel free to pop those in. But Sydney, you kind of have some personal experience with this, with your diagnosis. Do you mind to kind of give us a little background of your story and how you got here?
Yeah. So yeah, I was diagnosed in 2020, and I think I have kind of an interesting story because the first hospital I was at, the I they had a hard time keeping an oncologist in the colorectal cancer area, and so my first oncologist, if she did check my biomarkers, I was not told about it, and I didn't know to ask about it at that point. And my second oncologist did test my biomarkers, ran a Tempest test, which is a blood test. And, I was given the results, but nothing was really explained to me. And, I thought, well, if they're not going to explain it to me, why do I, why do I need to question anything? So it actually wasn't until I came to call on Congress in 2024 with Fight CRC, and I sat at my state table and met some other great advocates, and they were asking, "What are your biomarkers?" And they're like, "What do you mean?" I I don't know. I just have colon cancer. um, and they were like, "Well, have you had this test?" And um, come to find out, I did found out that I have the KRAS mutation, and TP53, and it wasn't until I switched hospitals and we checked the Tempest again with my new oncologist that I have now, and they really explained everything to me, and what treatments I can and can't do, what treatments work with my mutations, and what treatments may be resistant to my mutations. And earlier, like I said, I'm on the fourth line of treatment. And so unless I go back to the very first treatment, clinical trials are probably going to be my next option. And knowing that I have KRAS, we looked into the T cell therapy recently.
Yeah.
And since I don't have the G12 mutation, I unfortunately am not a candidate for that specific one. And since I found out that I do not have MSI high. So, a lot of immunotherapies will not be working for me. So yeah, it's really important to know these things, especially if you are a stage 4 patient like I am. And you can know what drugs are hopefully going to attack the cancer the best that they can. And like they said, you really need to ask your doctor if they're not going to explain it to you, because I was just like, being diagnosed with cancer is a lot of information already. And so I thought, well, they're just going to tell me everything I need to know. Which my oncologist now does tell me everything I need to know, thank goodness. But yeah.
Well, I'm glad you found an oncologist that communicates with you, but unfortunately, I've heard your story before from other people where I don't know if I've had this testing done, and they pull up their My Chart or whatever, patient app they have, and like, oh, well, yeah, here's testing, but it was never discussed with me. I had this done. I don't know if my treatment has changed before it. So it sounds like you found a good oncologist that likes to work with you, but you've also kind of taken some initiative and the specifics about your cancer. So yeah, I'm sorry you had to kind of go through difficulty to find someone that would communicate with you a little bit better, but I'm glad you did find somebody. So
yes, and thanks to Fight CRC, I did. Yeah.
Well, we're happy to help, and we're thrilled to have you at Call in Congress, and thrilled that you've joined us. So thank you so much, and thank you for joining us to share your story. I do want to be respectful of everyone's time. We've got about 5 minutes left. I do have a couple of questions that I've prepared, but if anyone has a question, throw it in the Q&A. We'll try to get to it. Dr. Roth, I have heard this from patients in the past that they've said they've undergone biomarker testing and the results have changed. Can your biomarker test results, your genomic test results change throughout your course of treatment?
It's a very good question. I guess there's two possibilities of that. One would be that maybe we just didn't detect it in the first time we checked it. So maybe if your tumor, the burden of cancer in your body was really low, you're not gonna, you won't always get have as much tumor DNA in your blood to detect. So as tumors grow, you might get more tumor DNA and be better apt to detect some of those mutations. The other thing I was going to point out, though, is that sometimes when we treat cancers, they develop what we call resistance mechanisms. And so an example that we can give is that patients that are given EGFR inhibitors with either panitumumab or cetuximab sometimes will develop KRAS mutations as cancers become smarter and learn how to grow around those drugs. So yes, they can change with time. And so I always think it's important, especially when we're getting to the point where we're kind of later in treatment, thinking about clinical trials. Let's say you had it tested a couple years ago just to get kind of a fresh look. And especially because sometimes the panels change. So I talked several times about how quickly things are changing. The tumor testing that you had, maybe before it was 400 genes, now it's 550 genes. And so that's more information that you can get.
So the landscape is evolving quickly. And I know you mentioned that, a while ago on one of those past slides, we thought this was an undruggable mutation, and now there are options. So these things change pretty quickly. And I know just trying to stay on top of FDA approvals and stuff can be a full-time job sometimes. So
yeah.
Sydney mentioned this, and I thought it was interesting that she has a specific KRAS mutation, but it's not one that made her eligible for a specific T cell trial. Genomic testing plays a pretty large role in your access to clinical trials and the therapies that you're available for testing. Is that true? Like, you need to know these things if you're looking to get involved in a clinical trial?
Absolutely. That's really the direction that most trials are going these days. Most of them are going to be, I shouldn't say most, but many of them are going to be looking at specific mutations in DNA. We don't have as many of the clinical trials that are kind of for all comers now. So knowing and even if they are, a lot of times they'll have exclusions, like they won't want to expose this drug to certain populations of patients with specific mutations. So it is very important when you get into the clinical trial space to know what your genomics are.
So I've got one more question before I start to wrap it up here, just to get everyone out on time, is do I need to be at a large academic institution to receive good genomic testing?
No, these studies are available to any oncologist. So there are several, I don't know if I can mention the names. This is not branded. I'm not getting paid by
No, yeah,
anyone,
you're fine.
so, some big institutions do have their own kind of homegrown next generation sequencing assays, but
Sure.
increasingly what we're seeing is that there are several specific kind of brands, so to speak, that we order. The ones that I can think of off the top of my head are going to be Foundation One, Tempus, Harris, Guardant, Natera. Those are all sequencing platforms that kind of do the same job, but they're all a little bit different and competitors with one another. So, but
Well,
yeah, you can get them anywhere. I'm in Missouri right now. You can get them in rural Missouri.
perfect, because that's kind of where I am right now, actually. So, but excellent. That's really helpful. And I think a lot of patients know the brand name of the test they've received and use that to communicate. They know specifically, I've had Signatera or what have you.
Right.
So that's no problem at all mentioning that. Well, Sydney, Dr. Roth, thank you both so much for taking the time out of your schedule to join us today. I really appreciate it. I want to go over just a couple of quick ways that people can get involved with Fight CRC. You can join our Resource Champions programs. We send out boxes of materials to patients or to you to distribute to clinics, health fairs, that kind of thing. It's all educational material, all medically reviewed and free to request. You can join us for in-person events, like Sydney joined us for Call in Congress 2 years in a row now, I believe. We have Climb for a Cure. There's others. We have our Research Advocacy Training and Support Program, which we affectionately call our RATS program. You can apply to join that. It brings the patient voice to research endeavors. You can apply to our ambassador program. It's really a good way for people to represent Fight CRC in a way. You can request resources to distribute for awareness, health fairs, or other events. And you can just reach out to us via our website, fightcrc.org, for other volunteer opportunities. For biomarker specific content, we have launched a biomarker state advocacy training within Community of Champions, which will kind of allow you to, or equip you with the knowledge and tools you need to understand and advocate for increased access to biomarker testing at the state level. So if you're interested in getting involved, if you're interested in colorectal cancer advocacy or just advocacy in general, join our Community of Champions app. Jump in there, take this biomarker state advocacy training school module, learn a little bit, see how you can get involved and make a difference. So I do want to thank Sydney and Dr. Roth again for joining us. I do want to thank our supporters, Amgen Oncology and Pfizer, for supporting this webinar and our biomarker educational content throughout the year. And I do like to end these webinars always with our mission statement. We are Fight Colorectal Cancer. We fight to cure colorectal cancer and serve as relentless champions of hope for all infected by this disease through informed patient support, impactful policy change, and breakthrough research endeavors. Thank you to everyone who joined us today for this webinar. And again, thank you, Dr. Roth, and thank you, Sydney. I really enjoyed this discussion today. Take care and have a great weekend.